there. So we'll get started with tonight's lecture. Thank you very much for coming along this evening, giving up your evening for the last monthly lecture of this academic year. We'll be back in September with some more, but we're having a bit of a summer break over August. My name is Zach. I work within the admissions and outreach team here at BSMS. Just to let you know a couple of things before we get started this evening. Firstly, this lecture is being recorded. We will send out the recording to you as soon as we have finished editing that after tonight. So don't worry if you miss little bits or if you have to dash out early. We will circulate that round to you. Secondly, if you do have any questions throughout the course of tonight's lecture, please feel free to pop them in the Q&A function here on Zoom, and we will try and answer them either if they're relevant as we're going along, or we'll try and answer the majority at the end of tonight's session. Okay, in which case I will hand you over to Dr. Anna Crown to start tonight's lecture. Over to you, Anna.
Thank you, Zach. So I'm just going to share my screen. Good. So hopefully everyone can see my screen. So the session this evening is called It Must Be My Hormones. And I'm one of the endocrine consultants. I work in Brighton at the Royal Sussex County Hospital and also for the medical school. So I've been working in the NHS for about 30 years. I've been a consultant endocrinologist now for about 15 years. And endocrinologists obviously specialise in hormone disorders. So that's what I'm going to focus on a little bit this evening. So hopefully some of the technological bits will work, because although I'm very good at endocrinology, I'm less good at technology. As Zach has said, do put questions in the chat, and I'm quite happy. Zach's going to moderate those to take questions as we go along and or at the end, if anything you want to discuss or anything that I say is not clear. So I thought to begin with, just to get a feel for me of what you know, what you don't know, and get a feel for you guys of the same, we could just ask you to just put some words onto a word cloud using the Mentimeter link. So the question is, what do hormones do? So really anything you can think that hormones do. So Zach's going to sort of launch the Mentimeter and take over and just start a word cloud where you can enter your thoughts about that question. So do contribute. Thank you.
Excellent. Yes, you should be able to see that on your screens now. The code for the Mentimeter is 26703003.
Brilliant. We're getting some good thoughts here. I like the term homeostasis. Lovely. Brilliant, brilliant, brilliant. Yep, we've got chemical messengers. Menstrual cycle, absolutely. Yep. So the idea that the hormones are having an indirect effect on other hormones, other organs transmitted through the bloodstream. Brilliant. Emotions, I like. Yep. Body functions, pretty much everything. Yeah, so we've got mother-child bonding with an example of oxytocin. We've got insulin and glucose examples, insulin and glucagon examples with glucose. Great. So we have got a lot of really good examples there. Gosh, look, lots of things. Appetite. Yes, absolutely. Brilliant. Growth. Yeah, I can see growth creeping in there. Growth, definitely. Brilliant. Good. This is great. Perfect. Negative feedback. Oh, endocrinologists love negative feedback. That is marvelous. Excellent. Good. All right. So I'm just going to reshare my screen or get Zach to unshare his screen. Oh, let's see if I can do this again. From current slide. Now, Zach, is that shared again?
Well, I can't see your screen at the moment, Anna. So if you
Oh,
want
I've
to
messed up. One
make
sec,
sure you
sorry.
click the share screen button first in
Oh,
Zoom.
what have I done? Share screen. Share. One current slide.
There you
Now we're
are.
back on track.
We've got
Perfect.
you
Good.
there now. Yes.
Thank you so much. So I'm sorry about that, guys. So I think you got a lot of these things, and it's kind of life, the universe, and everything, isn't it? So we've got appetite, weight, and thirst. So thirst, fluid balance, appetite, weight, everything to do not just with fertility, reproduction, but sex drive, all of that side of life, our energy levels, our sleep, growth and pubertal development. So several of you got that. Things like our bone and muscle strength, psychological well-being. So quite a lot of you talked about emotions, memories, and our stress responses and survival. So stress responses is actually the bit that I think we're going to sort of focus on this evening. So the next question before we move on, so another little word cloud, if that's all right. So where are hormones made? So again, I'm going to ask that to take over with the Mentimeter. And if you can just enter your thoughts about where hormones are made. So anywhere that you know where hormones are made, that would be fantastic.
Yep, the Menti slides are up there
Perfect.
again now.
So I
We've
can
got
see
a few
this.
coming in.
So we've got glands. Glands is good. Pituitary as an example, good. This is not exactly a trick question, but it's great to see all these glands. Look, brilliant. Pituitary, adrenal, pancreas, marvelous. No one's mentioned my favorite gland yet. Let's see if it comes up. Thyroid, great. Brain. Which bit of the brain? Adrenal medulla, very specific. Brilliant. Yep. Ovaries, hypothalamus, the best gland in the entire body. Brilliant. Whoever put that, gold star. Ovaries, glands, ovaries, marvelous. Perfect. Brilliant. Excellent. So you all know a lot about endocrinology already, which is brilliant. So I'm going to just try and share my screen again. And let us see if I can make this work this time. So you all got all of the hormone glands, which is brilliant, and you named nearly all of them. So obviously you've got ovaries, testes, adrenals, thyroids, hypothalamus, and pituitary. I think what we're learning more and more is that hormones are also produced by a lot of other tissues. So lots of tissues that you might not have thought of as typically endocrine are actively making hormones, and it's hormones in exactly the same way as other glands. So hormones that are released into the bloodstream, signaling to other tissues, signaling to the brain. So this includes our adipose tissue. That's not just a sort of store of tissue just sitting there doing nothing. It's metabolically active. It's making hormones. Our digestive tract, you know, how do we know if we're full or we're hungry? How do we know if we've just eaten? So your digestive tract releasing hormones, signaling back to the brain. The placenta is actively making hormones. Your heart makes hormones. Liver, kidneys, bone, muscle, skin, pretty much everywhere. All of these tissues make hormones. So you've got your traditional endocrine glands, but also hormone production by an awful lot of other tissues. So as I said, I think what I'll do in this session is focus in a bit on the hormonal stress response. So I'm sure you've all heard of cortisol as a hormone because it's quite a well-known hormone in relation to the hormone stress response. We're going to think a bit more about cortisol. And that's regulated by this axis, the hypothalamic, so that's hypothalamus, pituitary, adrenal axis. And that's what we're going to think about. So the hypothalamus, this gland that sits at the base of the brain, and we'll come back to that. The pituitary, which it signals to, which is the little gland hanging down below the brain. And the adrenals, as you know, sit on just the top of your kidneys like little hats and make a number of hormones, including cortisol. So we're going to think about what the stress response is and what happens when things might go wrong with the stress response. And in that, we're going to think a bit about some science. We're going to think a bit about some psychology, about some sociology, a bit about some medicine. So I'm going to try and do a bit of everything. So when we use the term stress, obviously stress is a term that we use a lot and maybe don't really think exactly what we mean. We quite often say, oh, I'm feeling really stressed, or work was really stressful. And it has all sorts of different meanings. So I've put a definition there on the left. So stress being either a real or interpreted threat to our physical or psychological integrity. So I think that's quite a nice definition, really, because it encompasses a range of different forms of stress. So traditionally, when we talk about a stress response, it will be something like you get run over by a bus and your body needs to launch into a stress response to try to pull you through that severe injury. An acute severe illness, you get meningitis or something like that. Again, your body's hormonal stress response has to get going to try and pull you through that stress. So that's what you might traditionally view as a threat clearly to your physical integrity. And then in more modern terms, we have emotional or psychological stressors. Many people live in socioeconomic conditions that impose a stress on their day-to-day life. We may be exposed to stress in our workplace, and that's a common source of stress, which again we'll come back to. And I will come on to further reading, but these two names here, Bruce McEwen and Robert Sapolsky, those are both great people to read if you're interested in this area to do with hormonal stress responses. They write really, really well, and I think, you know, very interestingly about this whole topic. So we're just going to do a couple of thought exercises. So try and kind of enter into the spirit of it, as in try and think yourself into the situation. We're just going to do 2 of these. So the first one is just try to vividly imagine that you're quite scared of the dentist, but you need to have a dental procedure. So that's the situation. So what would you do? So there's a range of things here. So I want you just to think to yourself or make a note to yourself, as in yes or no, which of these are things that you might do. So you're afraid of the dentist, you need to have a dental procedure. So would you ask the dentist exactly what they were going to do? Would you try to think about nice memories? Would you ask the dentist to tell you exactly when you would feel pain? Would you try to fall to sleep? Would you be watching all of the dentist's movements and listening to the sound of their drill? Might you try to do mental puzzles in your mind? Would you be checking your mouthwash when you spit out for any signs of blood? So just, you know, don't overthink it, but just think quickly, which of those would you actually think of doing in that scenario? And then we're going to do 2 of these. This is the second one. So hopefully this won't cause people too much actual stress, though hopefully you might start to feel your palms a bit sweaty and your heart racing a little bit. So we're vividly going to imagine that we're on an aeroplane. We're half an hour from landing when the plane unexpectedly goes into a deep dive and then it levels off. There's a little gap, a short time, and then the pilot says nothing's wrong, though the pilot says the rest of the ride might be a bit rough, and you're not really convinced that all is well on this flight. So that's the scenario. Okay, so I think we can all sort of imagine that scenario. So again, just thinking a yes, no, what would you do in that scenario? So would you carefully read the safety information, make sure you knew exactly where the emergency exits were? Might you try to make a bit of small talk with the passenger next to you? Would you watch the end of that in-flight movie? Might you try to call one of the cabin crew and ask them exactly what the problem was? Might you call one of the cabin crew and ask them for a drink? Would you start listening really carefully to the engines for any unusual noises and really carefully watching the crew's behaviour? Would you talk to the passenger next to you about what might have gone wrong? Might you settle down and try to read a book or a magazine? So again, just have a think in terms of a yes or no of what you would do in that situation. Try to sort of imagine yourself into it. So this is exactly the same scores, but you'll see here by each score I've put either an M or a B. So what I want you to do is just tally up with your yeses the number of M's and B's. So ignore anything you put a no to, but anything you put a yes to, tally up your total number of M's and B's. So I'll just give you a minute to do that. So anything you put a yes to, score yourself and just keep a total of the number of M's and number of B's that you scored. So hopefully I'm not making it too stressful by going too quickly. So again, this is the answer to the airplane one. So just anything that you said a yes to, again, tally, and it's a total running tally. So you can add this on to your tally from the dental questions. So what we want to know at the end of the day is for both questions, the total number of M's and total number of B's that you scored. So anything you put a yes to, count up the number of M's and B's, and then you're getting I want a total number for both questions, all added together. How many M's, how many B's? So I'll just give you a couple of seconds just to finish that up. So hopefully you've managed to do your little scores here. Good. So if you've managed to score things, I'm just going to ask Zach now to take over again and pop some graphs up. So with the Mentimeter, you can enter your total number of M's and total number of B's, and it will be two different graphs actually. So I'll ask Zach just to take over and display the Mentimeter for that.
Yep, we've got the Menti back up again now.
Great. Ah, brilliant. Very quick. Good. Interesting. So we can see already, I think, team, that this is not a normal distribution. We seem to be a bit skewed to the right here, don't we? Quite high numbers of M's here. So we'll let things level out a wee bit. Good, that looks about level. So it's a slightly skewed distribution. 6 seems the most popular. Quite high numbers of M's. Brilliant. So can we now have a look at the total numbers of B's? Is that all right, Zach? Ah, interesting. So we're skewed the other way, not that many B's. So you can see they're actually quite inverted, aren't they? So we tend to be a group that has high levels of M's and low levels of B's overall. That's pretty clear, isn't it? Okay, brilliant. Thank you for participating. So fine, I will now try and reshare my screen, and Zach can unshare his screen. So I think, you know, obviously that's it's a questionnaire, and what it's trying to look at is we all have different responses to stress. That particular questionnaire is designed to divide people into what they call monitors or blunters. So the M's are the monitors, the people who want to get as much information as possible. The B's are the blunters, the people whose response to stress is to try to distract themselves, you know, to think about other things. And I think it's interesting, if you guys are mostly, you know, wanting to be medics, you know, that sort of medical scientist mentality, you're mostly monitors, you're not really blunters. You're wanting as much information as possible, aren't you? You're not really trying to distract yourselves and have a drink or read a magazine. So that's kind of what I'd expect from this sort of group. But it's just a way of illustrating some of the differences in our responses to stress. So if we think about those stress responses and what causes them, obviously there are individual factors. So how do you perceive the risk? So that's obviously going to depend on a lot of factors. If I'm a skilled mountaineer, I'll perceive a risk differently to somebody who's a novice mountain climber. How distressing do you find the stress? So I think distress is an interesting term, isn't it? And obviously linked to stress, but some people thrive on stress. They love the adrenaline rush. Some people find particular stressors distressing. Our desire for information about risks, that's a bit the monitors and the blunters, you know, how much it's people differ in how much they want to know and how that affects their stress response. Our knowledge about the situation may well impact on our response to stress. So our knowledge, or indeed our lack of knowledge about it. How personally vulnerable do we feel? Do we feel we're in control, or do we feel very vulnerable? Are we the sort of person who does try to distract from or ignore things? And I think we all know that our mood can affect our stress response. So whether you're feeling upbeat or whether you're feeling low can affect your response to a very similar stress. So lots of individual factors. There are also situational factors. So are you supported, you know, friends, family, comrades, or are you rather isolated? This concept of control. So for example, at work, do you have control over how quickly you work, what time you start, what time you finish, how you do your work? Or is that really out of your control? Do you not have much autonomy? So it tends to be more stressful if you lack control. The demands imposed on you. Are you in a warehouse where there's demands to do everything in super quick time that you can't keep to? Is the situation new or familiar? So again, novel situations are often more stressful than familiar situations. Do the rewards match the effort? So you might feel that it's worthwhile doing something stressful if you're well paid for it, for example. Whereas if you're not particularly well paid, but the job's very stressful, obviously that is likely to be a less favourable situation. So thinking a bit about the evolution of our stress responses, and this is obviously simplified, but it's just a way of thinking about things that I think is quite interesting. So you've got the kind of maybe that very oldest stress response is still represented in our bodies by a parasympathetic nervous system, the vagus nerve. And this is a kind of freeze response. So this is if I'm a little lizard and something comes up and tries to threaten me, I might just freeze. I might pretend to be dead. I might make my body go really, really cold. So that's a very, very sort of primitive stress response, which is still, as I say, slightly preserved in our body by a parasympathetic nervous system. So that can slow our heart rate down. Layered on top of that, you've got your sympathetic nervous system, your typical adrenaline fight or flight. So the adrenaline, people mentioned the adrenal medulla. This is a brilliant stress response if you're, a saber-toothed tiger or a woolly mammoth suddenly pops up and threatens you. This is what you want to happen if you, have a road traffic accident. So that's the next level of our stress response. And in a way, the stress response we're talking about today is perhaps the more modern one, the pituitary adrenal axis or cortisol. And sometimes people call that tend and befriend, just to capture this idea that actually this is a stress response that can be influenced by other factors, for example, social support. And also that this is a stress response that can be triggered by things like, for example, public speaking. In a way, public speaking is a stressful task, but it's not a task that our more primitive stress responses were ever designed to tackle. So it's a sort of novel thing that we've had to develop ways of coping with. So when we started, somebody mentioned homeostasis. So homeostasis is your typical endocrine concept. So homeostasis, which hopefully you're familiar with, is the idea that you have feedback systems to keep everything constant. So that it was discovered by a Frenchman, so it was called the milieu intérieur, keeping that constancy of your internal environment. And that's clearly very important because a lot of things like the pH of our blood, our temperature, our blood glucose levels, which you mentioned, oxygen levels, these have to be kept within very tight and narrow target ranges for everything to function. But if you think about it, you need another system to enable you to respond to change. And that's been termed allostasis. So allostasis is feed-forward system so that you can respond to changes in your environment and then achieve a new stability through change. So in a sense, it's not good enough just to keep everything exactly the same. If your external environment is challenging you, you need to have a way of responding to that. And that's termed allostasis. So in terms of the allostatic system and the stress response, ideally what you want is to be able to initiate a hormonal response to stress. You need to be able to sustain that response until the stress has ceased. And then you need to be able to shut that response up as things recover. So you want that sort of a shape to the graph where you're initiating response, sustaining it, and then shutting it off once you recover. But again, McEwen initiated this concept of allostatic load. So this is the idea that actually trying to do this and maintain homeostasis when everything's changing becomes costly, that there's a cost to doing this. And it's the contribution of the cumulative effects of our physiological response can actually have an adverse effect on our health and adverse clinical outcomes. And that's what I'm going to just come on to discuss a little bit in relation to our stress response, particularly cortisol. So the idea that constant stress responses, although necessary, can also have adverse consequences to our health. So just thinking about our normal stress response, which is, as we said, sustained for a good interval and then turned off. What could cause an allostatic load? What could cause an adverse stress response or an adverse impact of the stress response? So one example would be repeated hits. If every day at work is equally as stressful as the last day at work, it never changes, it never lets off, your stress response is going to be active a lot of the time. And maybe your stress response doesn't adapt, even though you're exposed to the same stressors day after day, you don't adapt to those. Maybe you have a prolonged stress response that just never shuts off. And actually equally harmful, because there's a kind of yin and yang here. If you have an inadequate stress response, then that's not going to be good enough to pull your body through the stressors that it's exposed to. So there are various ways that your stress response can have an adverse impact on your health. So the concept is that we're all exposed to stressors. We've discussed the fact that how we perceive those stressors varies, and there's lots of reasons why that might be, individual and societal reasons why we might have different stress responses in terms of how we perceive stress. That then influences our physiological responses to stress, our hormone responses. That results in allostasis, which can result in adaptation, but also this allostatic load. So that's the adverse effect on your health of your stress response. So in terms of the individual differences, this may be inherited things that influence our individual differences, both in our stress perception and our physiological responses. There's good evidence now that how our in utero life, so before we're born, how things we're exposed to in the womb can actually influence our stress responses throughout life. Our very early life experiences can also influence our stress responses. And again, there's good evidence for that. So very early life influences can affect our hormonal stress responses. And obviously our current circumstances, as we've discussed, can influence our stress perception and our responses. And as well as the hormonal responses, obviously you have a behavioral response. So for example, if my response to a really stressful day at work is to go home, sit on the sofa all night, triple whiskies, cream buns and a cigar, that's going to have an adverse effect on my health, self-evidently, if that's my sort of behavioral stress response. So this is all the things that are going to influence our health, starting from stress and thinking about allostasis and hormonal impact on our health.
Oh, sorry to interrupt, Anna. We've got a couple of questions here,
which
I think would be
good,
quite good. So our first question is, what type of response would fainting be?
Well, that's interesting. So in some ways, fainting is your very, very primitive parasympathetic nervous system response. So some people, for example, if they need a blood test, actually will slow their heart rate down so much that their blood pressure won't sustain things and they will faint until they fall over. So that's potentially even an example of that very, very primitive parasympathetic nervous system response, which is common to things like, as I say, blood testing or other those kind of things that can happen.
Excellent. And the second one we've got here is, what is the relation between allostasis and stress?
So I think the concept is really that from your stress, so if you look at this slide that we've got in front of us, you start with your stress, then you perceive your stress, that's a brain thing. The physiological responses to stress is your hormones and your nervous system responses. Then the idea of the allostasis is that is a necessary response to a situation that's changing. So it has to happen so that you can adapt to a changing situation. But prolonged or excessive exposure to stresses can actually have a harmful effect on your health. So that's what we are going to continue to sort of think about a little bit more in a bit more detail.
Brilliant. This seems to have started a few different questions. So I think we'll have one more here, which is a good one. Can stress be a good thing?
Definitely. So say, for example, I'm a violinist and I need to play in a concert. Most people, or, I'm a 100 meters runner and I want to run a race. Most people will say that a degree of stress is really helpful to actually enable them to do their best performance in that situation. And I think many of us probably have that awareness that, a little bit of stress is actually, beneficial in terms of us and being able to be our best selves and make our best performance. And obviously stress is also part and parcel in life. It's literally impossible to live a stress-free life, absolutely impossible. We're exposed to stresses or hassles, you might call them, absolutely day to day. So part and parcel of life, good or bad. But I think certainly, there is, in terms of things like performance, perhaps even memory, there is that concept that actually a bit of stress is not a bad thing. And I think most of us will recognize that from our day-to-day lives.
Brilliant. We've got a few more, but we can always come back to those.
Let's do that. Let's do that. Thank you, Zach. Thank you. And thank you for your questions, guys. I'm very pleased that people are involved. That's fantastic. So this looks like a really complicated figure. What it's designed to do is show you the hypothalamus, which, as I say, has got to be the best gland, the cleverest gland in the whole body. So your hypothalamus sitting at the base of your brain, it's integrating all these different inputs. So it's integrating information about stress, all different stresses, might be pain. It's integrating information about infection. So this is inflammatory cytokines from your immune system. It's integrating things like your blood pressure, your oxygen levels. So all sorts of higher brain inputs are being integrated in the hypothalamus. and the hypothalamus is integrating those, and then through the production of hormones down to the pituitary and subsequently to the adrenal gland is regulating the cortisol. And those of you who mentioned negative feedback, genius, all of this regulated by negative feedback of cortisol at the pituitary and hypothalamic level. So a complicated picture, but designed to illustrate the sort of beauty of this whole system. And for those of you who want to be surgeons, anatomists, radiologists, neurosurgeons, this is what it looks like in the brain. So this is an MRI scan with the brain cut ear to ear. So your ears will be poking out either side. The hypothalamus sitting here, these glands here at the base of the brain. And here you can see this pituitary stalk, which comes down from the hypothalamus, leading to the pituitary, which sits in a little bony dish here. And just out of interest, this is the optic chiasm, the nerves from the eyes going back to the brain at that point. So that's the sort of anatomical picture of what we're talking about. So this, I just thought, be interesting to do a bit of data interpretation, because this is how endocrine scientists have started to understand cortisol and the stress system. So this is data from a real paper. And so what you're looking at here is they looked at people who were young or old. So I've only picked out the young people here. And they looked at people who were fed, as in allowed normal amounts of food, or fasting. So fasting is a type of stress. So fasting is a stressor from your body's point of view. And what you've got on the left-hand side is averages. So they averaged the results of the cortisol blood tests, and it's a 24-hour period from 8 a.m., 8 p.m., 8 a.m. So they averaged the results for people who are fed and for people who are fasted. And then on the right-hand side, you've just got examples of individual results, the fed and the fasted. And what you can see they were doing is they were just taking small amounts of blood very, very frequently and sampling them for cortisol and just looking at them across the day. So just have a little bit of a think about this. So first of all, I don't want it to sound too much like an exam, but as I say, this is how people started to understand cortisol in the endocrine system. So if you look at the average cortisol levels in the young fed people over the day, what do you notice about those levels? If you were to describe this graph to somebody who couldn't see it, what do you notice about cortisol levels in people who are just doing their thing, being fed and having blood tests taken across the day? So have a little look at that. You might want to make a few notes yourself of what you notice and how you describe that profile. So then part B of this data interpretation is just compare the average readings of the fed and the fasted. So this is the average cortisol profile of the fed and the fasted people. Again, broadly speaking, what differences do you notice there? What are the differences here between people who are fed and people who are fasted? And then just have a little look at the difference between when you look at average results and when you look at individual results, both for the fed and the fasted. So what do you notice there when you're just looking at what happens when you average your data and what happens when you look at an individual person's data? So hopefully what you've seen, and I'll just run through this, is that we have a circadian rhythm. So circadian just means during the day. We have variations in our cortisol levels. So our cortisol levels start to rise during the night. They peak just before we wake up, just before 8 in the morning. They fall in the day. So that all of us, quite normally, in the evening and nighttime, have very low levels of cortisol. So that's what's called the circadian rhythm of cortisol production. Now, fasting, which, as I said, is a stress, if you look at the average things, I would say that the key thing is you've kind of lost that circadian rhythm. So instead of having this trough in the evening with very low levels, you pretty much got high levels or relatively high levels across the whole day. And when we start to think about bad effects of cortisol and bad effects of stress hormones, you can imagine that if you've never got any period of time when your body's not seeing stress hormones, that's potentially going to have harmful effects on your health. And we can have a think about that. So even a simple stress like fasting is resulting in loss of that circadian rhythm. Obviously, you can see when you look at the individual things that hormones are released in pulses. So pulses, it's not a smooth tracing. Sometimes you'll see this reproduced as a really smooth curve, but hormones are never smooth. They're released in pulses. And when you're stressed, you can see you get more frequent pulses and higher pulses. So the stress response on an individual level is more frequent and higher pulses of cortisol. So hopefully you notice that as well. So that's just an example, which I think, that's basic science of how we start to unpick cortisol and the stress response and what it looks like. So this is pretty much what we were just talking about, the circadian rhythm and what it looks like, and the underlying pulsatility of hormone release, and seeing that increased frequency and amplitude of pulses in response to stress.
We've got a quick question here, Anna,
Oh,
which I
yes.
think is I
Yes.
didn't understand. I didn't understand what exactly is cortisol. Could you explain that, please?
Oh, I'm so sorry. So cortisol is a stress hormone that's produced by the adrenal gland. So it's your sort of, I guess, your main stress hormone produced by the adrenal gland. It's a glucocorticoid hormone, and in fact, I'm going to come on to tell you a little bit more about what cortisol does. So it's just coming. So it's a good question at the right time. So here we go, effects of cortisol. So stress hormone produced by the adrenal gland, and what it does, it's very important for our homeostasis in times of stress. So for example, hemorrhage, losing blood, it will help maintain your blood pressure. Infection, it will help damp down the response to infection so that our body is not overwhelmed by cytokines, which could actually have a harmful effect on our body. So it's important with maintaining blood pressure, blood sugar levels at times of stress. As I say, it does have an anti-inflammatory action. So in response to infections, you need to be able to mount an inflammatory response, but then you need to have a mechanism of damping that down so it doesn't overwhelm your body, this concept of balance, yin and yang. Cortisol helps maintain your energy balance, helps maintain glucose levels, helps keep your blood pressure up. It has an effect on cognitive function and memory and conditioning, and it's a particular type of memory. So you might have heard people say, oh, I always remember, where I was and what the pictures were like, for example, when the Twin Towers were attacked. It's that kind of, as it were, stressful memory, memories that are associated with stressful situations, which are literally imprinted on our brain and we can't forget them. So that's partly cortisol, which is having this effect on our cognitive function and memory and conditioning us. So people who get things like post-traumatic stress disorder is probably partly because of these sort of conditioned memories and the adverse effect. And it has other roles in terms of bone and cartilage, so lots of important roles. So we're going to go on to a bit of medicine now, but it's still cortisol. So this is a patient who came to see us looking like this and said, I didn't used to look like this. This is a photo of me how I used to look on the left. So she's saying, I've put on weight, particularly around my tummy and my face. You can see her face is all puffed up. And now I've got high blood pressure and diabetes. I'm just a young woman. I shouldn't be having these things. What is going on? And this is another patient. I didn't used to look like this, doctor. Look at me, and this is how I used to look. I've put on weight, my tummy and my face. I'm a cricketer. Whenever I play cricket and the ball hits me, I break a rib, and my mood's become really low. I've become really depressed. So what these people have got is a medical condition called Cushing syndrome, which is named after the doctor who discovered it, where they chronically make too much cortisol. And there's different reasons why this might happen, which we don't have to go into, but they are overproducing the hormone cortisol. So they get a syndrome where they get obesity, but in a very central deposition. So their face and their tummies gain fat, but in fact their arms and legs stay quite thin. And the fat gets deposited in funny places at the top of the back, around the face. And their skin becomes quite thin. They can get purple sort of stretch marks and bruise really easily. And with these high cortisol levels, all the things that cortisol does in a good way become exaggerated. So where we need cortisol to keep our blood pressure up, if you have too much of it, you get high blood pressure. Where we need cortisol to keep our blood sugar levels up, if you get too much of it, you get sugar diabetes. High levels of cortisol in excess cause depression. They thin your bones. You get osteoporosis, thin, brittle bones that can fracture and break. And while we're thinking about cortisol and diseases, there's a disease called Addison's disease where you make too little cortisol, again, named after the doctor who discovered it. If you have Addison's disease, you become very fatigued, you become very weak, you lose energy, you become very thin, you lose weight and appetite. You can get brown pigmented skin for reasons we don't need to go into, and you can't maintain your blood pressure, you can't maintain your blood sugar levels. So all the things you need cortisol for, you can't do, and that's Addison's disease, which is too little cortisol. So these are medical conditions, not to do with stress, but medical conditions where you either vastly overproduce or vastly underproduce the hormone cortisol and the effects it has on you. So as I say, cortisol can result in all of these things. It can result in weight gain, particularly around your middle, high blood pressure, diabetes, And all of these things increase your risk of heart attacks and strokes. As we said, it can result in depression, osteoporosis, and it also very high levels of cortisol will actually damp down and impair your immune response. So we've talked about Cushing syndrome, which is a very rare disease where because of a glandular problem, you're overproducing cortisol. But the way this links back to stress responses is people thought, well, what if because of your hormonal stress response, because of this allostatic load, because of constantly being stressed and constantly having a cortisol response, you could get a much milder form of this. So sort of like Cushing syndrome, but much milder. But this could be very, very much more common. So Cushing syndrome itself is really rare, but maybe because we're all exposed to so much stress and getting these sort of slightly higher levels of cortisol, like you saw with that panel in the fasted experiment, we have a sort of very mild version of this, and that's where the sort of problems to our health could arise. So the hypothesis is that differences in our stress response, neuroendocrine just meaning brain and hormone system, could at part mediate the differences we have in terms of our resilience or our susceptibility or our vulnerability to the consequences of stress. So how I respond to stress, how much hormone I make, my behavioral responses, that's going to influence my stress response. And that in turn is going to influence my risk of getting ill in the long term. And when we talk about illness, they're the really big non-communicable diseases that we worry about, the sort of giants of non-communicable diseases. So hypertension, type 2 diabetes, coronary heart disease, stroke, depression, dementia, osteoporosis. All of these are really important things. So is our stress response actually contributing to our risk of developing these as we get older? So this is building on the model that we've already discussed. So it's sort of building up that model that we've talked about. So something to do with our in utero life before we're even born, something to do perhaps, we don't have much food or our mother smokes, that sort of thing. Lack of care in early life. So we're constantly, our stress response is jumpy from the word go. We then get a job that's high strain meaning I don't have any control over it. It's very demanding. I have effort imbalance. I'm not paid very well and I have no autonomy in how I do my work. Maybe I get divorced or I'm socially isolated. So I've got a hyperactive stress system that then keeps being triggered by all of these socioeconomic problems that I've got. My behavioral response is adverse for my health as well. I'm smoking, I'm overeating. So my hormone stress responses are building up my allostatic load. So I'm getting this central obesity, central tummy fat, my cholesterol's gone up, I'm resistant to insulin, and this actually causes diseases, hypertension, diabetes, hyperlipidemia, atherosclerosis, and there's my heart attack. So that's the kind of model as how these hormones and our allostatic load could fit into this idea of risk factors for these sort of chronic health problems. Just a couple of things I thought you'd find maybe funny, maybe interesting, maybe curious. And these old studies, but they illustrate a little bit more about our stress responses and how interesting they are. So I'm not into gendered about this, but the question these authors were asking was, are there differences between men and women? So they looked at people preparing for a public speaking task. And as I say, that tends to be something people find moderately stressful and definitely triggers a cortisol response. So they either offered these people no support at all, they just had to get on with it by themselves, or they offered them support from an opposite sex stranger, or they offered them support from their own partner who was an opposite sex partner. So there were three options really. And what the supporters were told to do is they had to enact instrumental and emotional support during a 10-minute anticipation period. So basically, in the 10 minutes before this public speaking task, if you had a supporter who was either your partner or someone you didn't know, they could help you get ready for it. They could say, look, it's going to be fine. You're great. It's going to go really well. That kind of a thing for 10 minutes. So what did they find? So in the men in this study had a reduced cortisol response when their partner was supporting them. And that was seen when you compared it to either stranger support or no support. The women, interestingly, had a higher cortisol response when their partner was trying to support them. Though, again, curiously, the women actually rated the stranger and partner support more favorably than the men did. So their cortisol response is saying one thing, and what they're saying, as in reporting, is saying something else. And there seems to be a gendered difference here in the responses. Another thing that you might just find interesting, curious. So this was talking about stress-induced comfort eating. So they took a group of women in middle age, and they came for another stress test, so like a sort of public speaking thing. And after the session, so you've done your public speaking, you were then left for 30 minutes in a kind of waiting area with what they called leisure reading material and a snack basket. You were invited but not pressured to eat. And the study participants didn't know that their food intake was part of the study. They thought that the stress test was a study, and this was just, relax with something, a little snack and some reading material. And what the snack bars were was either sort of salty things like pretzels, salty savory, or sweet fatty things like flapjacks. So that's the scenario. And what they did then is they looked at people who had high cortisol responses to that stressful task, the public speaking, and people who had low cortisol responses. And that was, they called them high and low reactors. So very interestingly, the high reactors consumed way more calories than the low reactors did. And this is your snack basket after the task. You can see there 216 versus 137 calories. And it was mostly sweet things. So those high reactors consumed about 2 portions of sweet snacks compared to about 1 and a bit for the low reactors, but there was no difference in the consumption of savory snacks. So here's maybe an indicator that if we have a greater cortisol stress response, that might make us vulnerable to stress-induced eating, and not just stress-induced eating, but sweet, fatty foods. So obviously this does leave way for lots of questions. Is this something we can influence, or is this a fixed trajectory that happens from the moment we're born and we can do nothing about? If we can intervene, where should we intervene? What kind of level should we intervene at? So are we talking about individual interventions, and or are we talking about societal interventions? Is this we need to influence workplaces? Are we talking about medical interventions? Are we talking about drugs that would affect our cortisol production? Are we talking about psychological interventions or social interventions? Are we talking yoga, Pilates? What are we talking? And how are we going to assess the effect of what we're doing? So hard endpoints we love in medicine. So hard endpoints is who has a stroke, who has a heart attack, who dies. But obviously you can't just rely on those. You need to think about surrogate markers. People are interested in cortisol, of course they are, but you've seen yourself how hard that is to measure. It's got a diurnal rhythm, it's got pulsatility, it's influenced by all sorts of stresses. So it's a very hard one to study, cortisol, but obviously does seem to be an important player. So I'm going to stop in just 2 minutes so we can have some more time for questions. Before I stop, I just wanted to briefly try and sell endocrinology as a specialty to you. So endocrinology is a smaller hospital specialty in medicine. And these are some of the reasons why I think it's really, really interesting. So I love anything to do with human interest. I love soap operas. I like novels. So human interest for me is a really important thing in medicine. And I like holistic patient care. And both of those are really important in endocrinology. So you already saw when we were talking about Cushing syndrome, how it has a psychological component to it. And that's the same with many endocrine conditions. In endocrinology, you can help and you can make a difference. So what I mean is I can make a diagnosis, but then I can offer a treatment and management plan to the person. So some things we do in medicine, we can make a really clever diagnosis, but there's not a great deal we can do about it. Whereas in endocrinology, we can really make a difference. I see a very, very wide range of conditions. You yourselves listed all the endocrine glands. So in my clinics, I'll see people with problems from every single one of those glands, from things that are really common, so thyroid disease, quite common, diabetes, to things that are really rare, like Cushing syndrome. And I'll see people from every age and gender. So again, that's different to some branches of medicine. You need to understand the physiology. So those of you who are thinking about things like negative feedback, that's my day-to-day life is negative feedback. So understanding and applying the basic physiology of how hormones are regulated is how we unravel the clinical puzzles that we're presented with in terms of people's presentations and their blood tests. You do need, and this is common, I think, to a lot of medicine, to pay quite close attention to detail. You have to be a little bit obsessive in your attention to detail to be an endocrinologist. You often will look after people who are living with long-term conditions, and you're assisting the person to live with that condition, be it, for example, diabetes or the Addison's disease we talked about, where they need to have replacement with cortisol. So part of that is equipping the patient to manage their condition day to day, because they're doing that 24/7. But it's also nice to develop that kind of very lasting relationship with patients. Endocrinology does require you to be quite a generalist as well as a specialist. So you have to keep your general medical skills up, because patients often have consequences of their endocrine disorders that can affect, as we've talked about, their heart, their bones, their muscles, their brain. So you need to have generalist skills. Every day I work with multidisciplinary teams of wonderful people, nurses, dietitians, psychologists, all sorts of people, as well as other specialists. So, people who do imaging, with surgeons. So I'm constantly working with big groups of people, which again is part of the fun of medicine. And in endocrinology, as again, hopefully you've seen from this session, there's a lot of scope to be involved with research, either clinical research or basic scientific research. And this concept of bench to bedside. So you find a clinical conundrum, you then take that back into the lab or back to your animal model, try and understand it, and then reapply that back into the clinical situation. So endocrinology has a lot of scope to be involved in research. And then this is a bit of further reading if you're interested. So if you're just interested in what we've been talking about a bit, stress and stress responses, this is a nice book, Why Zebras Don't Get Ulcers. I like the title as well. And Sapolsky writes it's very easy to read. It's just a nice book to read. I would recommend the Society for Endocrinology. So they have a podcast called Hormones, the Inside Story. I had a look just before starting this, and recent entries include things like, can I hack my hormones to improve my mood? Is there really a fertility crisis? Menopause versus menopause? Should we have a steroid Olympics? So I think you'll agree there's lots of really interesting hormone podcasts on Hormones, the Inside Story. And if you just want to do a bit of research for your GCSEs or A-levels or other exams, there's a good educational resource, You and Your Hormones, which again is online, where you can just look up things if you want to get a bit more information about them. So I'm really happy to take any further questions and any discussion. Either through Zach or through unmuting, I'm happy to take further discussions and questions. And thank you for your attention as well today.
Excellent. So I will. There we go. So we've had a fair few questions come in. I'm aware we are getting to the sort of end of tonight's session. So I'll pick a few that are a little bit more general. And then if anybody does have any further questions after tonight's session, do feel free to email them to outreach@bsms.ac.uk. We can pass those on to Anna and provide some more information in the sort of follow-up email that we send out to you as well. So here's let's pick a couple of good questions here. So here's a good one. What would an inadequate response to stress look like, and what might cause that?
So an inadequate response to stress in a very broad form might be, for example, a very low cortisol response. So say, for example, you have a very severe illness, meningitis or something, and your body is not able to mount a sufficient stress response, then you might become more ill. And it's this kind of idea that you have a sweet spot. You need enough, but not too much in terms of your cortisol to mount the optimal response. Some of what I've talked about is there's a mix between theory and practice here, but we do know that certainly there is a sort of optimal stress response. It's like Goldilocks and the Three Bears, really. You don't want too much, you don't want too little, you want just about right in terms of your stress response to allow you to have the best chance of getting through stressful circumstances and illnesses that we all may come up against.
Excellent. We've got a really good question here. So we've had a lot of focus on stress and research around stress in recent decades. Is there evidence to suggest that stress and stress-based disorders are rising in the short term and perhaps in contrast to pre-industrial times, or are we better at finding symptoms?
So I think sadly at the moment, probably the answer to that is it's an increasing problem. And even, this isn't, so one of the very famous studies was done within Whitehall within the civil service, because the civil service has quite a structured grading system. So you can compare civil servants of all different bandings. So we're not talking about people who are out of work, unemployed, in really what you might call terribly stressful situations. But if you compare the top versus the middle and lower bandings of the civil service, you see very clear differences in health outcomes in the sorts of non-communicable diseases that could well be linked to stress hormone responses. So I think this is a really genuine problem, that does affect people, even if they are, as I say, employed in good jobs, but just, for example, having less control over what they do, high demand environments, not well well rewarded, those sorts of things. And I think it's something we probably haven't sufficiently really sort of tackled and taken on board. Obviously, in pre-industrial times, people would have been, exposed to all sorts of other stressors, but perhaps now everyone's living longer, we're actually living to see the effects of this sort of cumulative grumbling effect of stress in terms of the diseases we develop in later life.
Excellent. So we've had this question a couple of times, and I think it's always good to hear. So when did you realize that you wanted to work in endocrinology? What specifically made you choose this pathway?
Oh, okay. So I always just loved hormones. So when I was studying medicine, when we did endocrinology and hormones, to me, they just made sense. I loved them. I found them always very interesting. So then I was lucky enough, my very first job as a junior doctor, which now is 30 years ago, I worked for an endocrinologist, and I was so happy, and I literally followed him all around the hospital. He must have got thoroughly sick of me because I just trailed around after him, lapping it all up, and I'm afraid I was just sold from there. So it was partly a love of physiology, and I think I love the physiology, the way the hormones are regulated, and then I love the fact that when you do the specialty, to me it seemed very intuitive and straightforward because you're just applying that to people's day-to-day lives. And then I realized all the sort of interest of it that I tried to outline in that other slide. So it did happen early. It doesn't happen early for everybody. Some people only really find out what their niche is when they're a bit sort of further on through their career, but for me it was quite an early love.
Excellent. So we've had this question a couple of times. How do you manage emotional stress?
So obviously there is really no single answer to that. I mean, I think if we're talking about ourselves as individuals, I think partly it's maybe thinking about when we're talking about control. So we're all exposed to a lot of stress. Sometimes we can get very worked up about things we actually have no control over. So partly it may be about saying to yourself, look, I'm going to worry more about the things I have control over and a bit less about the things I have no control over. I think it's partly about working out, again, as an individual, what your counterbalancing things are. Is it Pilates? Is it yoga? Is it going for a run? We all gradually through life work out our ways of counterbalancing stresses and strains, don't we? And working out what actually is a healthy response for us, preferably that rather than as I say, sitting on the sofa with your cream bun and your triple whiskey. So, and then obviously there are psychological therapies that people can have as well. So I don't think there's a single answer, but I think, having thought about the things we're thinking about, hopefully that enables you to have a bit of a thought about how we can sort of handle the stresses and strains that we're all exposed to day to day.
Excellent. A really good answer. I think this might have to be our final question as we sort of finish up tonight's session. And I think it's a good one to finish on. So what are some of the treatments for Cushing syndrome and Addison's disease?
Oh gosh, well that is quite big to do in a minute, but we'll talk very quickly. Okay. So Cushing syndrome, first of all, you have to work out where in that axis is the problem. Is the problem at the pituitary gland? Is the problem at the adrenal gland? Sometimes, rarely, the problem is elsewhere, which is too much to go into. And usually the treatment is surgical. So once as an endocrinologist, my job is to work out what the cause of the Cushing's is. I will then be directing either a neurosurgeon to their pituitary or an adrenal surgeon to their adrenal glands. So that's Cushing's. Addison's disease, again, you clarify the diagnosis, and then what you do is you replace the hormones the person is not making. So we have a hormone called hydrocortisone, which is very similar to cortisol, and people have to take that daily. And we have a hormone called fludrocortisone, which is similar to a different adrenal hormone, and people have to take that as well. So Addison's disease is replacing the hormones that they should be making, and there's nothing you can do to regenerate the adrenal gland. The adrenal gland is already kaput, so you just replace the hormones they need.
Excellent. Well, thank you very much, Anna, for your talk this evening. It's been really informative, and I can see just from the engagement here is hopefully all of our attendees have found it really informative as well. Just to let you know, obviously this is we won't be having a monthly lecture in August, but we will be back in September with a further with our next talk, and we'll provide more information about that once we've sort of finalized exactly what's happening for that one. Like I said, we will circulate to you the recording of tonight's lecture as well once that's available. The last thing to say, just very, very briefly, is that we are hosting our final sort of open day at BSMS. So if you're interested in studying with us, it's a virtual open day. It's our last one. We've already had our in-person one for this year on the 30th of July. So if you're interested in that, there's more information on our website. So yeah, thank you very much again, Anna, and we hope that the rest of you have a lovely evening.